Palliative Care Needs Rounds are unique, evidence-based case reviews that improve palliative care for people living in residential care facilities. Bill has end-stage chronic airways disease and has had many admissions to emergency for respiratory distress. After being reviewed on a Saturday night by a locum, he is sent into ED again, and this time he dies in there. His family was unprepared. The aged care facility staff were distressed. Could we have changed these outcomes?
Needs rounds are monthly 60-minute staff triage meetings. At these meetings, staff discuss 3 to 5 residents who may have palliative care needs. These needs rounds are run by specialist palliative care clinicians or residential in-reach staff. All staff are welcome, including clinical care coordinators, care staff and general practitioners. Who do we discuss in a needs round? It would not be a surprise if the resident died in the next 6 months. There has been some physical or cognitive decline or exacerbation of symptoms in the last month. There are no plans in place for the last 6 months of life and no advanced care plan. There is conflict within the family around treatment and care options, or the resident was transferred to a residential aged care facility for end-of-life care. I want to discuss Sally. I've known her for a long time and lately she's lost weight and sleeps most of the day. She also doesn't want any further investigations. I don't think she'll be with us in the next 6 months.
I remember when I was working on Saturday, her daughter was very worried about her weight loss and was wondering if she should have investigations.
Well, let's have a chat with Sally's GP about her deterioration. We could organise a family meeting to discuss her goals of care. It's possible she may develop symptoms, so we must ensure we have anticipatory medications available.
Bill has had several admissions in the past few months. His admissions are more frequent and he's spending more time in hospital each time. He's really deteriorated lately. There was nothing in his recent discharge paperwork indicating a discussion about his goals of care either.
Do you know what he and his family understand about his prognosis and treatment options?
Yeah, he really hates going to hospital, but he does panic when he's breathless in his room.
Well, you could discuss his ongoing care with his GP and perhaps instigate some treatment, but if he's not responding, we can still manage his symptoms.
Judy has late-stage dementia. Her daughter came in to me in tears yesterday because Judy's son insists that she's got full resuscitation. She knows Judy would have hated to be as dependent as she is now and unable to recognise her family.
You know her daughter is the only one who visits Judy?
Does Judy have a medical power of attorney?
Her son is her financial power of attorney, but she doesn't have a medical power of attorney.
Well, can we arrange a family meeting with Judy's daughter and son? It's important we help her son understand that dementia is a terminal illness with no treatment options. We must respect what her wishes would have been.
Felicity has recently been diagnosed with metastatic lung cancer. Her GP arranged a review because she was becoming very breathless and she had chest pain which was just getting worse. Her daughters say that the oncologist has said there's no more treatment.
Look, she's frightened when you get her out of bed and she's too breathless to shower. She stays in bed most of the time.
Her O2 saturations fall to 70% at these times.
Felicity has a very advanced disease, according to the GP's notes. From what you've told me, her daughter understands her prognosis. She seems to be deteriorating quickly. Please ensure she has anticipatory medications. She is already on medication for her pain and breathlessness. We need to prepare for when she is unable to take oral medication. Can we ask her GP to write a script for replacement medications? You also said she was frightened. She is probably anxious about becoming breathless with exertion. I would suggest discussing management of her anxiety with her GP. She may benefit from something for her anxiety. Don't worry about taking her oxygen saturations. Her advanced disease will make it difficult to maintain them. It may only make her and her family more anxious. I think it would be a good idea to refer her to community palliative care. She's very symptomatic and is likely to require ongoing assistance with symptom management.
Can we discuss Elizabeth, who died last week?
Did you complete the death audit?
Yes, there were some things that we could have done better. She was an 80-year-old lady who'd been a resident for about 5 years. She was admitted with dementia and mild hypertension, but she had no other illnesses. She'd been deteriorating for about 6 months, nothing significant, but she'd lost weight and had stopped wanting to go to the lounge room, which was really unlike her. She spent her days sleeping in the chair. Last Saturday night, she was very drowsy and had a temperature when her son visited. We called a locum who sent her to the hospital. Her advanced care plan said she should be sent to the hospital and her son agreed. They commenced IV antibiotics in hospital. She was discharged that night, and hospital and the home were visiting and giving them twice daily. Sadly, she died 2 days later.
How do you think this situation could have been avoided?
We should have reviewed her goals of care. There were no discussions documented with her family, and I don't think they understood she was deteriorating. They just thought she was always tired in the evening when they visited.
She would have been someone we could have discussed at this meeting. We would have arranged a family meeting to review her advanced care plan and goals of care. Was she comfortable when she died?
She was restless, and hospital in the home suggested nursing her on a low mattress because of her delirium. The family were very upset by her restlessness. If we'd recognised her deterioration and prepared the family and requested anticipatory medications, we could have managed her symptoms more effectively, I think.
We are always happy to discuss residents who haven't had their advanced care plans and goals of care reviewed. It does sound like she was terminally delirious, and if we'd recognised that, we would have arranged medication to help her settle. Perhaps we should ensure the family have information about bereavement counselling. Needs rounds provide learning opportunities, clinical communication skills, talking with GPs and families, management of pain and other symptoms including delirium and dyspnea, recognising deterioration and diagnosing dying. When you're ready for more information about conducting needs rounds, contact your local community palliative care service.